Warm good morning to all. Welcome to our instruction course on CVI, Cerebral Visual Impairment. First of all, let me thank Ksos and Scientific Committee for including this CVI in this program. Cerebral visual impairment is the brain-based visual impairment caused by damage to the visual pathways and association areas. CVA is the most prevalent pediatric visual impairment in developed countries. Doctors and therapists are not prepared for it. This is soon to be true in India too. So we need to get ready because children with CVA can't wait. This year we bring the theme that CVA is multidisciplinary. So we have invited an eminent pediatrician who's doing her PhD in CVI, Dr. Parvati Mohan from Amalai Institute of Medical Science, Trichur, and an expert special educator who has undergone education leadership program of 9 months at Perkins Institute of Blind, US, Dr. Sini Reggie Thomas. And our faculty, Dr. Mallika and Dr. Sujata from Trichur Medical College. So I invite Dr. Mallika, to the professor, ophthalmology department, Medical College Trichur, for her talk on introduction to the CVA.
Good morning, one and all. You must have come across a group of children like this, a child with light gazing, a child showing atypical reflex, and a child showing absent light reflex, a child with a history of difficulty in finding his toy and small prints, a girl with deranged depth perception, a child with difficulty in climbing up or down the stairs, a child adopting his posture to read the book in order to avoid his field effect, child tripping over while walking. Do these children have cerebral visual impairment? That is what I'm going to deal with today. Cerebral visual impairment, as you know, is the deficiency in the function of vision. Something wrong with the visual pathways or processing centers in the brain, especially those posterior to lateral geniculate body. Eyes works fine, but the brain does not consistently understand or interpret what the eyes see. The occipital cortex is connected to other visual association areas to perform higher visual function through two streams. One is the ventral stream, which connects the occipital cortex to inferotemporal cortex and stands for the visual library or word pathway of brain, where prior memories of objects and people are stored and coordinated. The other is the dorsal stream, which connects the occipital, parietal, frontal, and motor cortex. It stands for visual map or visual space or word pathway of brain and helps to coordinate hand-eye movements on looking at a target object. So once you see such a suspected case of CVA, what history will you ask? You know that the hypoxic ischemic insult to the central nervous system is the major etiological factor in the CVA development. So these insults can occur antenatally, intrapartum, and postpartum period. So you should concentrate on the history of chorioamnionitis, antepartum hemorrhage, placental abnormalities, oligohydramnios, twin pregnancies, whether the mother had difficult delivery, prematurity, ROP, interventricular hemorrhage, and respiratory distress. Other causes of CVA are neonatal hypoglycemia, traumatic brain injury, congenital CNS malformations, CNS infections, hydrocephalus or a shunt failure, metabolic conditions, antenatal use of drugs like methadone, opium, benzodiazepines, alcohol, cocaine, seizure disorders, cardiac arrest and heart surgery, stroke or CNS tumors. So what next? What should be the suspected form of developmental history in them? If a child comes to you by 8 weeks with no eye contact or 3 to 4 months with no social smile, By 3 to 4 months, with no awareness of hands. By 5 months, there is no watching of hand movements or any squinting. By 6 to 7 months, there is no reaching out for any object, not recognizing faces. By 7 to 9 months. By 9 to 12 months, he doesn't point at pictures or pick up objects from the floor. By 1.5 years, he cannot put small objects in a container, does not point fingers when named, does not respond to mother's gestures, and seems to be in her own world. By 2 years, he cannot scribble, does not seem to understand or follow simple commands, or does not walk steadily. By 3 years, there is trouble climbing up and down the stairs, does not communicate meaningfully, cannot eat without help. There is continuous drooling and unclear speech. When you see such a child, you have to suspect there is some amount of developmental delay. There are 16 areas of visual behavior affected in these children. The child may have a normal function, normal vision or a subnormal vision, but may have some of these visual behavior specific to each child. We should know what is specific for each child, and accordingly measures are initiated to improve her visual function. Visual attention, they will have poor fixation, and the gaze from one point to the other is very poor. Visual recognition, they will find it difficult to recognize familiar faces and places. Impact of clutter is great. They find it difficult to, their visual function is very poor if they are put in a very crowded environment. Usually they will have an inferior field effect, but it is sometimes the gaze will be fixed in right or left. Impact of color, they prefer very solid colors like red or yellow. Form accessibility is also very poor. Visual guidance to upper limbs and lower limbs, there is poor hand-eye coordination, and they find it difficult to crawl or walk towards a destination. Access to people, they find it difficult to recognize people, even the mother or the caretaker. Impact of light is dual. Some CVA children prefer a brighter environment to perform well, whereas some prefer a dark room for that. Response interval is also very much delayed. Impact of motion is also dual. Some CVA children will prefer a static object, whether the other, on the other hand, some will prefer a motion object. Sensory integration is also very poor, and their performance is poor if with vibratory or auditory sensation. Visual curiosity for novel object is very poor in them. They can have nystagmus and squinting and gaze palsy, etc. So, how will you do the functional assessment? Is there any quantification method? This is more important for the early intervention specialist. Dr. Sini will be detailing more about this. According to the phase in which the child is presented, interventional measures are initiated. This is called CVA range. By a combination of observation, patient interview, and direct assessment, the examiner grades the child in 10 characteristics of CVA. These are color preference, need for movement, visual latency, visual field preferences, difficulties with visual complexity, need for light, difficulty with distance viewing, atypical visual reflexes, difficulty with visual novelty, absence of visually guided reach. So according to the phase in which the child is presented to you, interventional measures are initiated, and this will also help in the assessment of improvement in them. So what I would suggest is that there should be 3 must test objects to be kept in a pediatric ophthalmic OPD to pick up CVA easily. These are Lia puzzles and Lia mailbox. Either you can have the real ones, or you can even make your own thing with cardboard or a wooden thing which can simulate the same, which you can keep in your OPD so that you can recognize the CVA children and you can differentiate it from the OVA. The other object what I would suggest is the plus lenses, high plus lenses, +3, +4 or +5, because often we have seen that some children who fail to show proper fixation or follow movements, if you put a high plus lens, they will start showing some response. Usual ocular findings in these children are refractive error, hypermetropia is more common, accommodation dysfunction will be there, strabismus, exodeviation is more commonly seen than esodeviation. One particular pattern of strabismus is the shifting pattern, and they can have nystagmus, gaze palsy, and saccadic palsy. Optic disc changes they can have described are, one is the optic disc hyperplasia and the other one is the pseudoglaucomatous optic atrophy, which is more commonly seen in child with PVL. Whom should we order MRI? That also we should know. Any child with history of predisposing risk factors like birth asphyxia, neonatal hypoglycemia, neonatal seizures, STOMI postnatal cause, poor Apgar score, child with neuroregression later on, even if perinatal history was normal. So to conclude, time is crucial in diagnosing the leading cause of childhood blindness, cerebral visual impairment. While there is no cure, diagnosis and early intervention can unlock learning for these kids. These visual malfunctions can be easily overcome by simple environmental modifications, which can help the child to be a part of mainstream and help to perform academically and socially well. There is an acute need to create awareness about CVA in the ophthalmic, pediatric, and obstetric community, as well as the society in general. Thank you so much.
Thank you, Dr. Malika, for the illuminating talk. Now we move on to an important talk, that is the assessment of children with CVI. CVI assessment is required not only to diagnose, but also to plan the necessary intervention activities. So let's move on to Dr. Geeta's talk. She doesn't need any introduction. She's the pioneer of CVI in Kerala, and she's attached to the government, District Hospital Palakkad. Over to you, madam.
First of all, let me express my sincere gratitude to the pioneers in CVA, Dr. Gordon Dutton and Dr. Leah Hivernan, for the inspiration and guidance in our CVA activities. The CVA workup, there are 6 components for that. First of all, we have to diagnose CVA, because all children who come to the CVA clinic may not be diagnosed or referred. So, first thing is diagnosis. Then like half of the CVI which present in our clinics, they may coexist with ocular pathologies like squint, ptosis, or refractive errors, etc. So those should be diagnosed and treated. Whichever ocular pathologies which can be corrected should be corrected. Then do a proper dynamic retinoscopy to rule out accommodation lag. Then do cycloplegic refraction to correct refractive errors. Then come the functional vision evaluation and do a proper counseling. A word about counseling. These parents must have tired by hearing like this eye is normal, brain is abnormal, like that. They will be doing doctor shopping. But you have to tell them that how their child is seeing. For example, the lower field effect. You should tell them that the child is not able to see the floor. So that they can arrange suitable environment for the child to use the vision. And for habilitation, the proper habilitation can be done by explaining the vision to the parents. And always tell them that they are the persons doing the therapy, and we are always there to support them. This will make the compliance better. And tell them about neuroplasticity to improve the early intervention. So that is about counseling. Then how to diagnose? The CVI, like normally eye is normal, and the ocular findings may not explain the visual difficulties. But mind you, I have already told you that CVI can coexist with ocular pathologies. That is different. visual behavior may vary. The dictum is that they may vary depending on the child factors like fatigue or stress of the child, loss of interest, then environmental factors like clutter, visual or auditory clutter, then history of traumatic perinatal period may be there, latency will be prolonged, then visual attention span may be short, and difficulty with the crowded information, and associated motor and sensory cognitive difficulties. Cerebral imaging is MRI may show periventricular leukomalacia, but a normal MRI may not rule out CVA. And all children, CVA is a clinical diagnosis, so all children we need not go for MRI. And neurosonography, cystic changes of leukomalacia may be seen. It is predictive of CVI. VEP can indicate visual acuity, and it is used to differentiate CVI from delayed visual maturation, which is a differential diagnosis. Transdisciplinary assessment is needed. This is the classification by Dr. Gordon Dutton. That is children with profound visual impairment due to CVI. Children with, number 2 is children with CVI who have functionally useful vision and cognitive challenges. Third one is children with CVI who have functionally useful vision and who work at or near the expected academic level for their age group. That is called high functioning CVI. Now coming to the evaluation. It should be done in a special clinic, not in our busy OPD, because the visual clutter may affect the child's vision. Child should be well fed, had good sleep and comfortable. And sometimes neck control may not be there, so we can examine the child in supine. Then in CVI with profound CVI, sometimes sensory tent may be used. To prevent any omission, we use a Dutton's inventory, that which is we have translated to Malayalam. There are 2 types of inventories. One is for children less than 6/60 vision, and the other one is more than 6/60. I'm not going into the detail about it because we have some 48 questions in that. The dynamic retinoscopy is used to evaluate the ability to accommodate. Show an object at distance and note the retinoscopy reflex. Bring it close to the child and again note the reflex. If it changes from with to against, child can accommodate. If there is no change, that means there is accommodation lag, which can be corrected by +3 glasses. This child was some 6-month-old child, I think. It's not playing. Okay, the other there is no eye contact, and with the correction, the child is seeing. And this child, we saw got this child from a blind school. He is residing in a blind school. Parents thought he's blind. He is having blindism. See, he's having a stereotypical that repetitive movements. So when we asked the child to come to CVI clinic and assessed, and there was accommodation lag, and we gave bifocals. There was some astigmatism also. So now he is doing his routine. And this was a spastic diplegic child who was brought to our clinic for some certificate, not for assessment. And when we did cycloplegic refraction, her eye power, the power was -8. Okay, this and fundus examination is very, very important, because this child was brought by an intelligent mother saying that there is some problem, and there was no eye contact. I thought it was initial days. I was so excited to see a CVA case, and then I saw retinoblastoma, bilateral retinoblastoma. We would have diagnosed it later, but because we initially diagnosed, her vision in one eye was saved because fovea was not affected. So fundus examination is a must. Even the child comes at 3 months. Then functional vision assessment. That is to understand how a person uses vision to perform tasks of daily living in dynamic environment, which is done binocularly. So this is the protocol we follow for function vision assessment. Facial communication distance. You can use the mirror test also to know the visual sphere of communication, or go near the child with a silent smile. Then Liag ratings. This is preferential looking. This is the preferential looking is the principle. See, that is a 6-month-old baby. See how we can see whether the child can see the child's vision. And always explain to the parents the line thickness the child could appreciate compared to that of their fingers. Make them understand. Otherwise, there is no point in doing lots of tests. Always we should tell them. And in CVI, there are some special considerations. Saccadic eye movement may be affected, or sometimes head control may be delayed. Grating may be in the non-seeing part of the visual field, or presence of squint. All can affect this assessment. This is a Leah symbol book for pre-verbal children, preschool children. And this is for contrast sensitivity. If the child is responding with a social smile, he must have seen the picture of smiling face. See, this is the reduced contrast sensitivity with the same visual acuity. Then visual field. See, this is the field analyzer. The child will smile at this light. And otherwise, in an older child, we can use the leg rise test also. If the child can stand up and visual acuity more than 20/100. We ask the child to stand up and see whether he can appreciate the shoe. And other clues, like whether the child is always clinging on the sari, or whether the child is finding it difficult to climb the stairs, like that. See how she is appreciate that heel, movement of the heel. See. Then hemianopia. This is child with left hemianopia. Then latency will be more, and the span of visual attention will be less. And if there is profound CVA, that child should be assessed in a sensory tent with illuminated toy with auditory and tactile elements added to the stimulus. Light box also will be useful. This is the monochromatic sensory tent. Usually it is in the orange color. And evidence of blind sight should be looked for. Cognitive visual assessments. This is like as Dr. Mallika mentioned, this is the Leah puzzle. See, this 12-year-old girl, she's learning LD, and she can't appreciate the shape. And see this Leah mailbox. She is using the tactile clues. And Leah rectangles, all these expression, CVA children may not be able to see the, to recognize the expression. Eye-hand coordination should be checked, and visual closure. That is brain's ability to recognize a familiar word or picture when only a small part is seen. A child usually has somewhere around 1/3 of this 60 atypical visual processing functions. And our aim is to find and know the limits, and staying within them using alternatives, extend the limits. Thank you for patient listening.
Thank you, Dr. Geeta, for very good, very nice illustrative presentation. Now we next move on to other talk, our CVA clinic experience by Dr. Sujata from Government Medical College, Thrissur. She is the person in collaboration with the pediatric department in our hospital who started the CVA clinic. Over to you, Sujata.
Good afternoon, everyone. After an exhaustive talk on the assessment of CVI, Now, I would be sharing our experience at the CVA clinic of Government Medical College, which is functioning for the past 2 years. So my presentation will be involving how we set up that clinic, few interesting case scenarios, and the challenges we are facing. Started jointly by the departments of ophthalmology and pediatrics, our clinic is attached to the Early Intervention Center and Autism Clinic, regional, that is REIC, which is attached to the, which functions in the annex building of our medical college. We all know that REIC is a clinic where a team of different specialists work together to help children with developmental delay. Our CVA clinic attached to this REIC adopts an interdisciplinary approach, which is considered to be the gold standard. That is, a child coming to our clinic is first seen by a pediatrician who rules out any motor, sensory, or intellectual issues, does all the needed referrals, and any visual abnormality, the child is sent to the CVA clinic. And our CVA clinic is surrounded by the offices of the pediatrician, psychologist, speech therapist, and physiotherapist. And all the services a child with developmental delay coming to our clinic is met under one roof, which is greatly appreciated. Our clinic has a very quiet environment, spacious waiting area, and we have all the basic special equipments for CVA assessment arranged in a clutter-free environment. So as Madam already said, the evaluation, very few points. The evaluation of our child in our clinic also starts with noting down a detailed history, medical record evaluation, and then a look into the anterior segment, posterior segment, and refraction will rule out any contributing factors for ocular factors, and also the accommodation lag if it's present. Then we move on to the various aspects of functional visual assessment, like the visual acuity, which may be tested by the LEA paddles. Field of vision, which again, as Madam said, it's usually tested by using a LEA wand, and also contrast sensitivity by using a hiding HD test. We also have other instruments, like already mentioned, LEA puzzle, which tests both the dorsal and the ventral stream, and the LEA mailbox. So these are the few aspects of functional, all aspects of functional assessment are assessed. And now this is important to plan the intervention strategies for these children. They are planned putting together the medical history of the child, observing how and when the child is using its vision, and also, as I mentioned, all the functional aspects of functional vision, and also understanding whether the child has any other disabilities. Then the broad principles under which we work are, that is, children with high risk, that is neonatal hypoglycemia, are all screened very early, and also early intervention is advised. And each child with CVA is different, and so we plan a tailor-made approach for each child. And it is always a teamwork between the parents and the therapists. So in very young children or children with profound CVI, we may have to start with the vision stimulation activities. These are done by the office-based therapy sessions or by regular home exercises which can be supervised. Then we always encourage a regular follow-up to further assess, and also to know how much improvement the child has. So the vision stimulation activities can be done in the normal light using a patterned chart or toys, or the environment can be modified by using illuminated toys in a dark room. Then we also do lighthouse activities. You should note that each child, as Malika already said, has preferential light. So each child has his or her own favorite color, and that is being used as the stimulating toy. Then in older children, We plan the strategies according to the problem the child is basically having. And this child, you can see with inferior field impairment, is encouraged to walk down the steps. And the child with optic ataxia is given exercises which improve the hand-eye coordination. So these are the few examples of few intervention strategies. Now we move on to case scenarios. First, to tell us about the importance of early assessment and intervention, and the other two are two of the confusing cases we had last year. So this is a 1 month old boy with a diagnosis of hypoxic ischemic encephalopathy, picked up from the NICU, where our optometrist does weekly rounds. He was advised vision stimulation activities. The parents were very regular in follow-up and also passionate in doing home exercises. So by 6 months of age, the child developed fixation and following. But he then had certain setbacks, like he had seizures, was put on medications. But the parents continued all the interventions, and at 1 year we have a very visually active child. But this child, again with the same diagnosis, it was not so fortunate. She was again also picked up from the same ICU, was advised early follow-up, but the parents brought the child only after 9 months of age. And then we due to certain family issues, then we started vision stimulation activities. But now after she is more than 1 year and 4 months, there is no satisfactory improvement in fixation or any visual awareness. So this may be due to the late intervention strategies which was started very, very late. And now the third case is this is a 3-month-old child referred by a nurse from the health center with the concern of child is not looking at mother's face or at any toys. When we saw the child, she had no developmental delay or no other problem, but we noticed that child is not at all visually active. So we again started vision stimulation activities. Then it was noticed that from the home videos they send for review, there is an abnormal movement of the feet. So the child was recalled for the pediatric evaluation, and she had a very abnormal EEG. MRI showed atrophy of brain, and then we did a genetic study also that showed that it is a rare case of autosomal recessive condition which caused progressive encephalopathy and brain atrophy. Now this is an 8-month-old child with no visual awareness. He had some developmental delay. He was brought to us. Then, but in his case, his abnormal seizures and EEG was picked up, and a diagnosis of infantile epileptic spasm syndrome or West syndrome was made. Interestingly, we had 2 other children with the same diagnosis. So now we come to the challenges we are facing. Let us see the statistics. For the last 1.5 years, we had screened 68 patients with CVI, and then most common neuroophthalmic association is hypoxic ischemic encephalopathy. But let's see what is the amount of low functioning CVI we are having. That's 59 out of 68 children, and this daunting majority of profound CVI is the major challenge we are facing, because it's very difficult to maintain and encourage these children with CVI and intervention strategies. And then, as everyone is saying, it's a lack of awareness of CVI among the general public, which also includes the medical practitioners, which leads to the late referral. Then the final question is, are we missing out on children with high functioning CVI? Do we need to screen susceptible population like children with learning disabilities, children with minor CNS insults during the childhood? So with this, I'm ending my presentation with sincere thanks to our REIC team, and of course, Dr. Geeta, who is always a great help. Thank you all.
Thank you, Dr. Sujata, for this the wonderful presentation. Now let's invite Dr. Parvati, who was the former professor of pediatrics at GMC Trichur and nodal officer at REIC Trichur. Now professor of pediatrics and head of child development center at Amala Institute of Medical Science, Trichur. Welcome, Dr. Parvati.
Good afternoon, everyone. First of all, let me thank Dr. Geeta and Ksos for giving me this opportunity to be here to speak at this important workshop. So, as the previous speakers have said, cerebral visual impairment is visual impairment due to a problem in the brain and not in the eye. The child sees, but the child cannot make sense of what he sees. So why is CVI missed? CVI is missed because eye examination is normal. It is often maybe diagnosed in a young child as delayed visual maturation. Once an ocular problem is diagnosed, people may not think beyond this diagnosis. There would be other urgent medical issues like seizures, developmental delay, etc. and the difficulty in examining the child. These are the important factors why we miss CVI. So who sees children with CVI? Of course, the ophthalmologist, but they don't come so frequently to the OPD. Similarly, the pediatrician also, the general pediatrician also doesn't see cases of CVI. These children usually come to the neonatologist when they are in the follow-up clinic, the pediatric neurologist when they come with delayed development of seizures, to the developmental pediatrician. Sometimes they go to the psychiatrist because they may have behavioral changes resembling autism, AD or ADHD, and they are very often picked up by therapists now, the speech therapist, the special educator, optometrist. All these people are more aware of CVI than we are. Now, why is early diagnosis of cerebral visual impairment important? The eye contact develops by 6 weeks of life, and if eye contact has not developed by the age of 8 months, you should consider it as a developmental emergency and look into it. Okay, this is the development of the brain. The brain, only 25% of the brain development is over at birth, and maximum development occurs in the first 2 years of life. You have a large number of neurons and connections, but after the age of 2 years, these connections and synapses come down. So what you have to do is, you have to act early. If visual impairment occurs early in life, it can affect mobility, because children see and learn. It can affect mobility, it can affect communication, it can affect activities of daily living and learning. So you have to pick up CVI very, very early, and you have to start your intervention. This is called habilitation. Before the child develops handicaps, you have to start your visual habilitation. Now, the prevalence of CVI is the studies from India are usually from clinics, specialized ophthalmology clinics, and prevalence is reported to be about 33%, and combined with OVI, it's about 44%. Now, we did a survey of the retrospective analysis of the cases we had seen between August 2018 and May 2020, when we started this Regional Early Intervention Center. Dr. Sujata was speaking about. The center we had a high-risk clinic where we followed up newborns who had moderate to severe problems and were at risk for neurodevelopmental disorders. In 2018, this was upgraded into a Regional Early Intervention Center with a multidisciplinary team. So we did an analysis of the cases we had seen so far, and there were 53 cases. The average age at diagnosis was a little late, 24 months. It should not be so. There were more males than girls, and many of them had ocular problems in association. And of these children, 66% had a birth weight below 2.5 kg, and those who were low birth weights were term babies. So we had more of term, small for gestational age babies than preterm babies. So the risk factors for CVI have already been mentioned. So these are the newborns or the babies who come out of the ICU who are at greatest risk for CVI. So in our study, again, we found that HIV was the most important, hypoxic ischemic encephalopathy or birth asphyxia was the most important cause, followed by hypoglycemia. Epilepsy. Of these 6 children had seizures, and 3 children, 2 of them had West syndrome and 1 had Dravet syndrome. Meningoencephalitis, hydrocephalus, cortical dysplasia, a metabolic disorder, glutaric acid type 2, and a genetic disorder which was a 12p deletion found in a child who was born by IVF. So there is a slightly increased tendency for CVI to occur in children who are born by artificial reproductive techniques. Now, when should a pediatrician suspect CVI? When a child has the above mentioned risk factors for neurodevelopmental disorders, or when a child comes to you with a neurodevelopmental disorder like cerebral palsy or developmental delay, when there are unexplained visual problems, even after correction of vision, the child still, the parent still feels that the child has a visual problem, and when you find abnormal neuroimaging findings in the visual association areas and in the visual pathways. Now, what are the features in different age groups? So, children present in different ways in different age groups. In an infant can present, this is a 2-month-old baby and this is a 5-month-old baby. This 2-month-old baby was brought by the mother with a history that the child was not looking at her face or there was no tracking movements. So what we did was we examined the child was perfectly normal, all other milestones were development and this child was born preterm. So this you can call, this condition is called delayed visual maturation. If all milestones are delayed and the child is preterm, you start habilitation, the child will usually pick up. So this child again brought at the age of 5 months with a history that he was not looking at the mother. So we examined him, showed him a bright object. He was not tracking the object, but the response is when he was shown a rattle, the response was better. He was responding better to auditory stimulation rather than to visual stimulation. The response is obviously better. Again, this is look, when we took the history, this child had an episode of seizures at the on third postnatal day. Seizures which occur on the third postnatal day are usually due to hypoglycemia, and seizures which occur on day 1 are because of hypoxic ischemic encephalopathy. This was the MRI. There was parieto-occipital gliosis extending here more to the parietal area. So this child also had an associated weakness to the upper limb and lower limb. So he had hemiplegic cerebral palsy as well. So when you get a lesion like this, always look for limb movements. Now this is another baby, just as Dr. Sujata said. This baby was also brought with the history that he was not tracking or fixing his vision on any objects. You can see that he's just not looking at it. So this is because the baby had continuous seizures. This is the pattern of the EEG. It's called hypsarrhythmia. When the child has seizures like this, all his developmental domains will be arrested. So once you treat the hypsarrhythmia, the child will start improving. So whatever it is, you start your visual stimulation, visual habilitation, and treat the seizures. Very, very important. Now there are structured questionnaires which will help you to screen infants for CVI, and these are the questionnaires: the short visual skill questionnaire from Ulster University and the Spanish questionnaire by Pio et al. They're very helpful for eliciting the history. Now, how does a toddler present to you? The toddler usually presents with history of delayed milestones. This was a child who came to us suspecting autism. So he wouldn't open his eyes and he would just move around in circles. He had severe impairment. He was not speaking. He wouldn't use his hands for any purposeful movements, and there was no communication at all. So when we took him to the dark room, you have to always check vision in a dark room. He started slowly opening his eyes, and with habilitation he has really improved. So typically children who have movements at the level of the upper limbs take a very long time to improve. When they don't have any fine scale movements of the hands, it takes a long time for improvement. Now again, these are toddlers with occipital gliosis. Both of them had hypoglycemia in the newborn period, and here the injury is confined to the occipital cortex. It's called occipital gliosis, and when you have a mushroomed appearance, it's called oliguria. So again, another child with optic ataxia brought, this is the same baby you saw in the picture, the baby aged 5 months who had no visual fixation or tracking. We corrected his visual problems, and this is, you can see the optic ataxia. So in the older child, again, you can test with the Lia puzzle or the Lia mailbox. They may have associated inferior visual defect. Some children may come to you with head tilt, some may have photophobia. Again, look at the difference in the child after his vision has been corrected with glasses. So older children can be having high functioning CVI or low functioning CVI, like this child who was suspected to have a learning disability. And this is a child with whom Dr. Geeta had also seen. Again, he had features of autism, but it was because of CVI. Again, another child had moderate impairment with features of autism. We had to let her play on the swing, and only after which she came to our room for visual examination. So these are the diagnostic criteria. It's a diagnosis of exclusion, history of a neurological condition, presence of visual behavior characteristics of CVI, and eye examination. This does not explain. So it's a clinical finding. When you find abnormal neuroimaging findings like this, always suspect CVI. And when all of them had associated impairments in our series. The most common was seizures. You subject them to a detailed examination. Associated ocular impairments have to be checked and you have to correct. This is a child who had Balance syndrome with optic ataxia and oculomotor apraxia with simultaneous agnosia. So he's not able to shift his eyes. So these are some of the important references, and my many thanks to the Department of Pediatrics, GMC Thrissur, to the REIC, Department of Ophthalmology, Radio Diagnosis, and also to Dr. Maya Padmanabhan, who bought us the LIA tools for assessment. Thank you very much. Thank you for the patient hearing.
Thank you, Dr. Parvati, for that wonderful presentation. Now, let me invite Dr. Sini Reggie Thomas. She is a special educator and head of the Department of Special Education Needs at Trivandrum International School. With over 15 years of experience, she has pioneered many educational initiatives, earned many awards, TESS Award, and and she's a recipient of the Inspire 3 Special Educationist of the Year Award. She's also the first Keralite selected for Perkins School for the Blind prestigious Global Education Leadership Program. So, welcome, Dr. Sini.
Thank you. Good afternoon, everyone. After listening to so many technical terms, I was like so shocked, maybe like some of the videos. So hats off to all the ophthalmology surgeons. So my goodness, such a wonderful job you all are doing. So you all will be wondering like what a special educator doing in this conference. So first of all, my hearty thanks to Dr. VKP Geeta for giving me this wonderful opportunity to meet you, such an awesome population. So myself, Dr. Sini Reggie Thomas, I'm heading the Department of Special Education in Trivandrum International School group of institutions. So last year, I was so fortunate to be selected one expert from India to attend the Global Educational Leadership Program in Perkins School for the Blind, Boston, USA. So CVI, cerebral cortical visual impairment. I'm not a person to talk about the more technicalities, so I'll be more talking about the educational management side. So it is a brain-based visual impairment caused damage to the visual pathways or visual processing areas of the brain. So it is now the leading cause of blindness and low vision in children. Recent studies estimate CVI may affect as many as 1 in 30 children in mainstream elementary schools. This highlights the urgent need for awareness and adaptation in inclusive education settings. Inclusive education, children with disabilities studies in regular schools along with their neurotypical peers. So let's look at the educational implication. To truly support children with CVI, we must focus on tailored educational approach. I know that earlier speakers, they were also like very focusing, they were telling about the customized approaches to make learning accessible for them. It can be in terms of curriculum, assessments, physical education, then adapting the environment, creating classrooms where children with CVI can learn without any barriers. These principles form the foundation of effective inclusion. CVA poses unique challenges for educators. As Christine Roman Lancy says, CVA is a disability of access, specifically access to the visual field. Children may struggle to visually engage with learning materials, interacting with peers, and their environment. To address this, educators must adopt customized strategies to ensure both these students can actively participate in schools. Let's explore 5 key strategies to support children with CVI. The first one, need for individualized support. Each child's experience of CVI is unique, shaped by various factors. For example, lighting or visual fatigue. There are 16 visual behaviors are mentioned in the Perkins CVI protocol, and then the development of individualized education plan in collaboration with specialists in essential. So in our school, each student under SCN program, they will be having individualized education plan. Let's go to the next principle, that is multisensory learning. CVI limits visual processing, so children often rely on auditory and tactile inputs. Incorporating hands-on activities, sound cues, and textured materials can greatly enhance learning. Classroom adaptations. Minimize distractions like visual clutter or poor lighting. We should be very careful while adjusting the lighting. Majority of our children are having seizures as well. And then use high contrast materials and structured environments to support their processing abilities. Then it is very important to modify the teaching learning materials. We have to simplify the complexity of the visual representation, use large font and spaced text, and mark the salient features. These adaptations help children focus on the key details. So you can see this is one of the strategies, like a word bubbling, the presentation of the materials in a black background. And usually we will be using, some of the students will be having difficulty in neck control, so we will be using a slant board in front of the child so that it will be very easy for the child to look upon. Next is, if you see the tortoise, and then the child will be finding difficulty to understand the end part, so we can do the marking. Use of assistive technology, tools like screen reading or magnifiers enable access and promote independence. So some of the key points to remember, there are additional considerations to keep in mind. Children with CVI need time to interpret and process visual information, avoid rushing them. When they come to the school, often the early intervention starts very late. So when they will be coming to us, like the teachers, we have a tendency to ask and talk a lot. So we will be having a strategy called wait. Wait means, why am I talking? So we have to process and then pose questions and then process for 1 or 2, 4 seconds and then talk next. Functional vision. Teach strategies for visual scanning and recognizing key features to maximize their residual vision. Address frustrations that stem from visual challenges by offering positive reinforcement and encouragement. Teachers must be trained in CVA-specific strategies, functional vision assessments, understanding on Perkins CVA protocol, and then CVA range, and attends inventory through workshops, hands-on training, and resources. Hardly I can see all these things are incorporated in the visual impairment, the teachers of visual impairment curriculum. My hearty acknowledgements. Before concluding, I want to acknowledge those who have guided my understanding of CVI. Their contributions remind us of the importance of collaboration, of creating an inclusive world for children with CVI. In conclusion, when we adopt our teaching and learning approaches in classrooms and attitudes, we can create meaningful learning experiences for children with CVI. By incorporating these considerations, we ensure they receive equitable opportunities to learn, participate, and succeed alongside their peers. Thank you for your patient listening.
Thank you very much, Dr. Sini, for your wonderful presentation. And any questions from the audience?
So, do you have a customized proforma for the patient? So, have you made your own proforma, or are you, do you customize it according to the type of CVI, or do you have one proforma for all?
We have made one proforma for all the patients, and some patients like profound CVA, where we cannot see all this cognitive function and all, we leave it. But sometimes when this child, when they grow up, we may have to include those tests in this thing as an evaluation later on when they come for review.
Okay. And then do you have a score at the end of it based on which you chart out the management protocol?
No, we don't. That is CVI range she was talking about. Actually, we don't use CVI range in our this thing. We follow that functional vision protocol brought about by Dr. Niranjan Pehre. That was given in our CVI manual when we got trained in CVI at national level. That appears to be a good compact thing for us. CVI range that needs more people for assessment, repeated assessment.
Probably important for special educators.
Maybe.
And one more thing, how often do you do a VEP in a patient who is suspected to have CVI? Like sometimes, like you said, no, this a child may be brought at 3 to 6 months of
Yeah.
age. So assessment is not really, nothing much may be possible if the child is visually not responsive. So apart from the history, do you incorporate VEP in your clinical practice?
Like when we suspect delayed visual maturation, maybe
That's
this is
probably
not.
you would term it as DVM then.
Yeah, DVM.
But do you do a VEP just to make sure that,
We don't usually back because our patients. I work in a government setup, so it's difficult for us to get a
but,
VEP.
what about Trishur? I think you have a VEP, right? In your neurology department would be
We
having
have a neurology, maybe EP, but that's also we only refer selectively. But we had a study in CVA in our clinic by our PG student. So everyone was advised VEP, that was taken.
So because I'm a pediatric ophthalmologist. So what I found is that at least we can reassure them. See, the myelination may not be complete, so it may not be 100% accurate. But at least if you get a good, reasonably good VEP, you can probably prognosticate a better outcome rather than Dr. Parvati. Would you like to add?
Yeah.
Pattern VP. I mean, yeah, but that's true. Ideal is a pattern VP. Yes, I do agree because that quantifies the visual response. But in my experience, what I've seen is if you need to repeat it. A first VP may not be 100% accurate, but at least children with DVM, most of them when you have a normal VP, if you repeat it after 6 months, and then definitely you'll also see a corresponding improvement in the visual milestones because DVM usually improves. So anyway, I had a very good talk. Congratulations to all the speakers.
Do you like to share your experience?
No, we don't have a CVI clinic, but we are in the process of.
I heard that you have been doing in special schools.
Yeah.
You have been visiting.
So we do see children with neurodevelopmental, and we have a tie-up with some special schools for screening. So that's one major lacuna what we still now have is because we are a standalone eye hospital. To incorporate a CVI clinic requires multidisciplinary approach. But we are in the process of starting one, so that's why I just came. But we have started screening. We used to screen. Screening was a major difficult part. So we used the photo screeners that would give us some inputs to what children have, ocular problems which can be amblyogenic risk factors which can be corrected and would make some, like as you said, some children who are autistic, who are labeled as autistic,
Yeah.
would dramatically become all,
Yeah,
the
correct,
behavior
correct.
changes if you give them a proper astigmatic correction or proper glasses. So that difference we saw. Yeah, but the major drawback we are having is in the rehabilitation part, because it requires a multidisciplinary approach. And even I have seen the behavior of children with squints, infantile esotropia. Some of them, like the cerebral palsy patients, may have esotropia. And I don't know how it is, but when their eyes are aligned, their behavior totally changes. They fix better and they become more active. So this
Actually,
is
that
something-
child who was in the last slide, that was an infantile ESO, which was corrected. And
Yeah.
now she's going to a normal school, almost normal.
Yeah.
Yeah.
So I encourage parents to correct, if you get at least good readings and reasonably good measurements, to correct them so that at least that part is taken care of.
Okay, thank you.
What is needed is the time and patience.
Yeah, that is correct.
So that's very true, because that's what I find in my practice also, because we have a busy OPD. Then to see a child with special needs, you need a special environment. So that is why we are also starting to think that we need a special place to see these children. You cannot see them in your regular OPD when you have 50 screaming children waiting
Yeah,
outside.
correct.
Yeah. Okay, that's true.
So
We have only two OPs for CVA screening every month. That's in a different place, not connected to our OP or pediatric OPs, but same floor. And it's also a challenge. I find it's a challenge to also to quantify the improvement in children also. Datans which we translated to Malayalam and then
Malayalam and then
back translated.
Just wanted to add one point. Perkins have a model program strategy where actually they are looking for some potential partnership with existing centers where they can come and give kind of like a mentoring and then kind of support. So if you are like anybody interested, please let me know. Okay, thank you. So right
Yeah,
now
that
all the
is-
Perkins CVA protocol, so we all are learning about it, and then we're actually potentially looking forward like some partnership where we can explore more into CVA protocol. Thank you.
So it's all teamwork. That is what I find. Like, yeah. It is said, if you have to reach fast, you have to walk alone. But when you have to reach far, you have to walk together.
Yes, yes.
So let's walk together. And
And whenever they will be suspecting any kind of difficulty, and you are the primary point of contact, and your guidance. I thought like time is finished. Okay, so the right guidance to the parents and the early intervention. I have done my course in early education. The importance of brain development. I was so fascinated. Oh my goodness! First 3 years, it's like almost everything done. 40% of the adult mental abilities formed, and then children are coming to our hands in the age of like 4.5, or like now NEP is saying like 6. So NEP is like so I'm just asking like okay, is there any exemption for children with special needs? No, they should be reaching in our hands like at the earliest. So I cannot like make them wait till they reach 6. Thank you so much.
so now I invite Dr. Parvati to collect the gift. You give. അവിടുന്ന് കൊടുത്തു. Let's take a photo. Yeah, let's take a photo.